Hi, I'm Dr. Scott Tauber with the American Institute of Personal Injury Physicians. And today we're going to discuss the neurological examination of the personal injury patient. And we're going to cover the aspects of deep tendon reflex, sensation, muscle testing. We're going to touch on cranial nerves and mental status. This is an often overlooked part of the initial evaluation in many physicians' offices. But I want to stress that it's important that you perform a neurological evaluation so we can rule in or rule out many neurological conditions such as radiculopathy and even mild traumatic brain injury. But it also is important because it plays into your billing code. If you're not performing a complete neurological evaluation, you may not be getting to the level of the E&M or evaluation and management code that you want to go ahead and bill for and you choose at the end of your evaluation. So pay attention and do not skip the neurological evaluation. Let's go ahead and get started. So the first part of our neurological evaluation, we're going to evaluate sensation. In this case, we're going to use pinwheel. Keep in mind you could also use a pin, a safety pin, a paper clip. You could also use a disposable pinwheel. So you have different ways of applying this test. Also keep in mind that this test requires a lot of subjectivity. We're going to evaluate, we're going to ask the patient for their response, but we truly don't know whether they can feel it or not. So we're going to evaluate the upper extremity. When we evaluate the upper extremity, if the patient has sensation distally, then we can assume that they have sensation proximally. So for C6, we're going to run this gently over the web of the patient's index and thumb. We're also going to come down and test their fingertips, asking them if they can feel that sharp or any area feels dull. If you want, you can go back and do the entire extremity, C5, C6, C7. But again, in order to cut right to the chase, we're going to just examine distally. Also, you can take the back end of this and go for dull, seeing if they can identify this as dull versus sharp. Then from this position, we're going to go down to the lower extremity, and we're going to go over the inside of the foot, over the dorsum of the foot for L5, and then we can test the S1 dermatome along the outside of the foot. Notice for demonstration purposes, I did L4 and L5 on one foot and then went over to the opposite so you could see. Obviously, we're not going to do that in clinical practice. So the neurological evaluation using sensation is extremely important. You may not pick up specific dermatomes in the upper extremity because there's a lot of crossover, but you might see that more in the lower extremity. Your documentation, though, is extremely important. You want to make sure that you document any decreased sensation or diminished sensation in the specific dermatomes, and that would lead to the possibility of referrals for MRI or orthopedic or neurological consult. And that concludes the evaluation of the upper and lower extremities with sensation. The next part of our neurological examination is going to be evaluation of the deep reflexes. There are many different types of hammers available. This is the most common found in most physicians' offices, but I prefer the Babinski hammer. It's a little bit heavier, it's weighted, and it's easier to obtain the patient's reflexes. The key to reflex testing is testing for symmetry. For demonstration purposes, however, we're only going to test one side. Keep in mind, when you test one reflex, you're going to immediately test the opposite side. So we're going to start off with the upper extremity, going to have the patient relax, and we're going to test the bicep reflex. We're going to hit our fingers. Notice we're looking for symmetry. This would be a normal reflex. We can test the radial reflex, and then follow up with the triceps reflex. Again, this is not maybe the most ideal position, but for demonstration purposes. In the lower extremity, we have the patella and the Achilles reflex, looking for extension of the leg. And the Achilles, we're going to dorsiflex and looking for plantar flexion. And so again, symmetry, testing both sides. Normals, make sure your documentation is either plus or 2+. That is the established normal for documenting deep reflexes. If there is hyporeflexia or hyperreflexia, that is abnormal, make sure you document that. That is indicative of neurological disorders, and you definitely want to make the appropriate referrals for additional diagnostic testing or to a neurologist and allow them to make the determination for additional diagnostic testing. That concludes deep reflex testing. The next part of our neurological examination is muscle testing of the upper extremity. For demonstration purposes, we're only going to test one side, but in clinical reality, you're going to go ahead and test both sides. The other important thing to remember when you're doing muscle testing is to do 3 repetitions, a minimum of 3 repetitions for each muscle tested in order to pick up those subtle muscle or neurological weaknesses. So we're going to test the upper extremity. We're going to place the patient's arm into abduction. We're going to test the deltoid. We're going to ask the patient to resist as we push down on the elbow. So I want you to resist as hard as you can. And again. And one more time. Excellent. And you notice the 3 repetitions. Next, we're going to go into the biceps. Resist. I'm going to push down. And one more time. Don't let me pull your arm down. Excellent. And one more time. Good. We're going to do triceps from the same position. We're going to push the arm towards the patient. Resist. Resist. And one more time. Resist. Notice my hand position and the stabilization of the other areas. We're going to have the patient make a fist, dorsiflex, bend your wrist back, and we're going to go ahead and push down, resist, and again resist, and again resist. We're going to keep that position and bring it under. We're going to try and bring up the patient's wrist, resist, and again, and one more time. Excellent. And that's a very thorough motor testing evaluation of the upper extremity. The next part of our muscle testing examination is going to be muscle testing of the lower extremity, and we're going to test the quadriceps and the hamstrings first. So we're going to have the patient extend their leg a little bit, and we're going to ask them to resist our pressure back down, again 3 times, resist, good, and resist, and as hard as you can, resist, good. And from there we're going to have the patient relax, and we're going to try to bring the leg forward 3 times, relax, good, and again, real hard, and one more time, good. Then we're going to test the ankle, have the patient dorsiflex, bend their foot back, and we're going to ask them to resist, ready, resist, and again, one more time, good. And then down, excellent, and we're going to attempt to bring it back up, ready, resist, and again, and one more time, good. The next muscles we're going to test are the hip flexors and the hip extensors. So with the patient in the supine position, we're going to bend up the leg, and we're going to ask the patient to resist our pressure, trying to push their knee or thigh back down. So I'm going to have you resist, and again, and one more time. Excellent. Then we're going to have the patient turn over onto their stomach. We're going to test the hip extensors. We're going to bend the leg up to 90 degrees, have the patient extend their thigh up off the table. We're going to stabilize the lower back, and we're going to attempt to push the thigh back down towards the table. Ready? Resist, and again, resist, and one more time, resist. Excellent. And this concludes our muscle testing examination of the lower extremity. The next part of the neurological examination is extremely important. It's the mental status exam. And this can be done to evaluate patients that have had a head injury in their motor vehicle accident, and also to help us with MTBI, TBI, or some sort of post-concussion syndrome. There's a couple different ways of doing this. The first thing that you can do is give the patient a series of numbers and then ask that patient to count back those numbers backwards. For example, 9, 5, 3, and 2, then ask the patient to count back those numbers to you, starting with 2 all the way back to 9. Another component of the mental status is to give the patient 5 different words, such as door, table, chair, water, and outside. And then have them later on in your examination repeat those words back to you. If they're unable to do the counting or the repeating of the words, that may be indicative of some sort of brain injury, and you definitely want to consider a referral to a neurologist, a neuropsychologist, and additional diagnostic testing, considering a CT or an MRI of the head or brain. So make sure that you include a mental status examination as part of your neurological evaluation. The next part of our neurological examination is cranial nerves. In this part, we're only going to show cranial nerve number 1. However, we want to make sure that you evaluate all 12 cranial nerves bilaterally. The reason why we're showing cranial nerve number 1 and how to perform this test is because cranial nerve number 1 is the most commonly injured cranial nerve with direct head trauma. So in motor vehicle accidents, if the history is telling you a direct head trauma or a head injury, you want to make sure that you evaluate cranial nerve number 1, and oftentimes physicians do not. They usually evaluate cranial nerves number 2 through 12 and miss this particular finding. So what we're going to do is we're going to have a vial in our office of a non-noxious substance, coffee or mint or tobacco. And we're going to have the patient close their eyes. Then they're going to occlude one nostril. In this case, it's going to be the left. We're going to take our non-noxious substance and pass it underneath their nose and have them identify what that substance is. When we're done, we're going to repeat the test. So we're going to have them remove their hand, occlude the right nostril, and then we're going to do the same thing on the opposite side. So it does take a little bit of preparation to have this in your office, a vial of either coffee, mint, or tobacco, but testing of cranial nerve number 1 is extremely important. And so make sure that you do this along with the other 11 cranial nerves. The next part of our neurological examination is cerebellar testing. And in this particular test, we're going to do finger-to-nose testing. The patient is seated. We're going to ask the patient to close their eyes and extend their arms out, and then approximate their index finger to their nose, starting with the right, and then with the left. Very good. And you could do this test standing as well. However, you run the risk, if a patient does have a cerebellar problem, that they're going to lose their balance. So it's best to have the patient seated for patient safety's sake. And this is finger-to-nose cerebellar testing. So the next test for our cerebellar testing is finger-to-finger. In this test, the patient is seated, their eyes are open, and it's done very similar to the finger-to-nose. The patient touches their nose first and then is going to attempt to touch my finger. After they've successfully performed that, I'm going to move my fingers and have the patient do it again. So the eyes are open, the hands are extended. I'm going to have the patient touch their nose first and then touch my finger, then the opposite side. Very good. Now I'm going to move my fingers and I'm going to ask the patient to do it again. Very good. And that concludes the finger-to-finger test and the cerebellar testing of your neurological examination. And this concludes our neurological evaluation of the personal injury patient. Make sure that you perform a quality and thorough neurological examination as part of your initial exam for the reasons that were mentioned at the beginning of this video.